Hi, everyone, and welcome to this week's Healy Community Q&A webinar. If you're tuning in this week, you are in for a very special webinar topic. But as we're waiting for people to filter in from the waiting room, you can take a moment to sign up for the ALS link. It's our email broadcast system announcing the webinar topics when we have special guests and special topics. And if you head to the next slide, before we actually get into the presentation today, because I want to hand it over to our guest speakers, but for those who are just joining, wanting to let you know that we have a really great lineup of webinar topics coming up. So March 12th, we'll be joined by Dr. Jinsey Andrews and some members from CLEAN to give an update about the CNM AUA EAP. March 19th, this is big news that we'll have a dedicated drug science webinar about Regimen I of the HEALEY ALS Platform Trial with Neurofilament Therapeutics. And then on April 2nd, Dr. Suma Babu will give an update about the HEALEY ALS MyMatch clinical trial program. So lots of great topics coming up if you want to tune in for any of those. But for this week, if we head to the next slide, we are joined by clinician and researcher Dr. James Barry from Mass General, as well as wonderful biostatistician Jenny Wang, to talk about neurofilament light chain, which if you've heard of before, you might have some background knowledge of, but if not, we're going to delve into everything that we know so far. So with that, I'll hand it over to you, Dr. Barry.
Thanks so much. I'm really excited to be here. This is a topic that we talk about a lot in ALS drug development. We have for many years, but it's become, I think, increasingly important in drug development and really trying to understand how the details of neurofilament has been important to us. And I think it's really important for people in the ALS community to understand why it's so important and what we're trying to accomplish by understanding neurofilament further. Next slide. So neurofilament is a structural protein in neurons. And so it's sort of like a scaffolding protein. It kind of gives the neuron its shape, especially the long projection of the neuron called the axon. And it holds that shape. And when the neuron becomes ill, neurofilament can be spilled into the spinal fluid, which we call CSF, and into the blood. So as that axon loses its shape and loses that scaffolding, it kind of comes apart and it then goes into the spinal fluid and blood. And neurofilament is kind of a broad term. It actually really talks about primarily three different proteins: neurofilament light chain, neurofilament medium chain, and neurofilament heavy chain. Now, the medium chain is actually probably kind of variable. It's a little bit hard to detect and measure and quantify. The heavy chain, actually, there's some stuff that happens to it called phosphorylation, where there are these phosphorus sort of pieces that get added to it. And initially, we thought that would make it easier to detect, and it over time made it so that the best one for us to detect at this point is neurofilament light chain. Neurofilament light chain is a protein that we have the ability to detect in the blood and the CSF. And interestingly, when we look in the blood and the CSF, the level of neurofilament is much higher in CSF, probably because that spinal fluid surrounds our brain and our spinal cord, and there isn't very much of it compared to how much blood we have in our body. So it's just more concentrated there. But the levels correlate very, very highly, and we've seen this in a number of studies. You can see one graph there where there's that kind of sort of comparison of dots, and it basically goes in a diagonal, and that shows us that there's a good correlation. So if it's higher in blood, it's going to be higher in spinal fluid as well. And that means we can, for the sake of ease, we can check it in blood rather than having to check it in spinal fluid. Next slide. Now, when we set out to detect a biomarker, there are lots of different ways that we can use a given biomarker. We might have a diagnostic biomarker. Blood sugar is like that. So for diabetes, if we measure blood sugar and it's too high, then the person has diabetes. It has to be measured on a number of occasions, but that's how we use it to diagnose it. When someone comes into the emergency room and we think they might be having a heart attack, we can measure something called troponin in the blood, and that's a diagnostic for a heart attack. That's not the way that neurofilament is used, actually, because it turns out neurofilament is actually in all neurons, not just motor neurons. So it's not specific to ALS. So we have to be careful about using it as a diagnostic biomarker. But it does have some really important uses. One of those is in prognosis. So if we know that somebody has ALS, then we can measure the neurofilament light at baseline, like when they come into us. And that can be a suggestion of how quickly ALS will progress in the future. And if we think about all the things that we might measure, how long it's been since symptoms started, ALSFRS-R on a certain date, um, any of these things that we measure, vital capacity, NFL is actually the best single predictor of future progression. It's still not that good. I don't want to give you sort of a false sense of how good it is. It can account for some substantial percentage of kind of how much, understanding how much change is, how quickly change will happen in the future. When we use it clinically, we kind of think of it as sort of a, likely to be slow, likely to be somewhere in the middle, and likely to be faster. That's kind of the degree that we can get out of it. When we use it in clinical trials this way, we're usually thinking about, trying to create a group of people for a clinical trial that makes sense, that sort of somewhat like one another to reduce the noise. And we can also use neurofilament as an outcome measure, a biomarker, an outcome measure biomarker. That is to say, treatment effect. So we can measure neurofilament over time. Sometimes that's called longitudinally, and we expect it to be stable. And that's based on a lot of data from small studies, and we'll show you sort of, Jenny's going to talk you through what we see in some large studies. If neurofilament decreases when somebody is on an investigational product, on a study drug, then it could suggest that investigational product, that study drug, slowed the disease. We have to be careful about that, and there are lots of questions that Jenny's going to walk us through, like how much does it have to decrease for us to think that? Next slide. So just to show you some of the data that says to us that neurofilament is a good prognostic biomarker. Lower CSF neurofilament predicts slower progression. Lower CSF neurofilament predicts longer survival, and lower plasma neurofilament predicts longer survival. And I could pull up many, many, many other studies that show you similar findings. Next slide. So neurofilament is what we call a pharmacodynamic marker. That is a marker that a drug is hitting its target and affecting the disease. Well, tofersen is a drug that is used to treat ALS that's caused by a mutation in SOD1 mutations. And tofersen was tested in a clinical trial, phase 3 clinical trial, smallish, because SOD1 ALS is only about 2% of all ALS. And this drug is really focused just on SOD1 mutations. In the blue here, I don't know if you can see my cursor. The blue line shows us what happened to the placebo participants. That is, the neurofilament was stable or actually increased just a little bit. The red line shows us what happened to the treated participants, and there you can see that the neurofilament went down by about more than 50%. After we get to the right of that vertical dashed line, that's when everybody started the active treatment. It's the open label extension. So the people who had been on placebo now started actually getting tofersen. And you can see that after they started getting tofersen, their neurofilament also declined. So it was sort of like a confirmation that what we saw in the treatment group happened again. And this is turned out to be not only proof that the drug would be successful, and in fact, after the neurofilament came down, we saw clinical slowing of the disease, but it also reinforced that we can use neurofilament this way, that it's a good pharmacodynamic marker, a good marker of drug effect. And so it is now being incorporated into a lot of clinical trials. Next slide. But there is still a lot to be understood. In the tofersen trial, everybody who got tofersen is in green here, and you can see that anything below that horizontal black line is a reduction in neurofilament. And most people who got tofersen went down. You can see one person over here that's green that went up, and you see a lot of blue that went up. Up. Well, we thought neurofilament was stable. So that begs the question, how much of the time is it not stable? How much of the time is it going up? And if you just follow people who weren't being treated, would it ever go down, and how much? We need to know these things in order to know how to use it in a clinical trial. Next slide. So today, Jenny is going to tell us about two clinical trials or clinical studies, one clinical study, one clinical trial, and about how neurofilament behaved in those studies. So the first one is Answer ALS, which was a longitudinal observational study. It enrolled 1,000 people, about 800 of them had ALS. It collected clinical data, including ALS-FRSR, and there were visits every 3 months over a year. The follow-up was a little variable. And we collected blood as well, and neurofilament was analyzed. So observational study, no treatment. The HEALEY ALS Platform Trial, I think people are familiar, is a clinical trial with multiple regimens that occur in parallel and serial. And we looked at neurofilament in people from the placebo group. Here, visits were every 2 months over 6 months, so sort of a shorter follow-up, but a more regimented follow-up, and neurofilament was analyzed. Next slide. All right, and Jenny, I'm going to hand it over to you to walk us through the findings.
Thank you very much, James. So, okay, first, I am going to talk about the NFL in its role as what we call the prognostic biomarker. And again, just like what James just said, when we say the prognostic, we mean that NFL levels at the group level are associated, if the NFL levels are at a group level, are associated with how the ALS tends to progress over time. And before sharing any of the findings from our current research, I want to pause and emphasize something important, that out of the findings that in our current research really just describing the patterns across many people, and they're not really just prediction for any one single individual. Next slide, please. So this slides really show the results specifically from the data combining the HEALEY ALS Platform Trial regimens A through E placebo groups. And it's about how the NFL predicts the rate of functional decline. We looked at whether the NFL level at the start of the study were associated with how the function changed over the following month. When we talk about you can see the y-axis here is the slope of ALSFRS here. We mean that on average, how quickly that the ALSFRS total score change over time. Or you can interpret that as like a slope of -1, meaning losing about 1 ALSFRS point per month. And we took all the available visits in the placebo groups and during the trials across the regimens over time for each participant, and then estimate their over trend. That is how we got that slope. And what we found here that on average, participants with higher NFL levels at baseline tend to have steeper ASFRSR slope, meaning faster functional change. And that tells us that the NFL reflects the overall disease activity, but again, there's wide overlap between the individuals, and two people can have similar NFL values and very different functional trajectories. So this does not really mean that a specific number definitely will determine what will happen. And it just means that across large groups of people, NFL carries very useful information about disease biology. Next slide, please. So now we shift from prognosis to how the NFL behaves over time. Some of our current research we're interested in say, does NFL itself change over time, like what just James described in one of the waterfall plot? And also some questions like, can it serve as a useful measurement in the clinical trial? So in this next section, I will talk about the NFL not really as the predictor of the outcomes, but as something that we can measure rapidly over time and how stable or variable it appears in two mentioned large analytic data sets. Next slide, please. We start by looking at repeated NFL measurements collected over month on the individual levels. This analysis was based on the data from HEALEY ALS Platform placebo group. In this analysis, we focused on participants who had at least 2 NFL measurements during the 6 months follow-up period. There were 331 individuals included. It's also very important to note that almost all the participants in this analysis had experienced the symptom onset more than 6 months already before they had the baseline NFL test. So this finding primarily reflect individuals who are already beyond the very, very earliest phase or disease at the time of the measurements of NFL. What we do was to calculating how much each person's NFL values vary across the visits over the 6 month period. And the main finding is that the bulk of or majority of the participants showed very stable NFL levels over this 6 month period. About 95%, which is 314 out of 331 individuals, had NFL levels that remained within a relatively narrow range over time. And for these participants, the typical variation between the tests of NFL were around -11% to +12%. The rest, about 5% of participants whose NFL values shows greater variation compared to the previous mentioned 95% of the cohort. This accounts for 17 subjects, and we found that in this small group, NFL levels could increase by up to 40% or decrease by about 29% between one specific test and their own mean trajectory. I want to emphasize that this does not mean that their NFL levels steadily increase by 40% or steadily decrease by 29% over time. It just means that at least the one measurement during this 6 month period to show a change of that magnitude compared to their own estimated mean trend. And specifically, there within this small group, there was 70% of participants had their NFL levels increased by 40% or more from their own mean level in at least one test. And 35% of participants have their NFL levels decreased by at least 29% from their own mean level in at least one test. These findings are really helpful for us to understand what normal short-term fluctuation look like in this specific clinical setting. Next slide, please. Okay, we talked about the individual trajectory, and now we take a look at how the trend look like at the group level. This plot shows a percent change of NFL from baseline over the 6 months, and the distribution, and also I show the distribution of the changes at each checkpoint at week 8, week 16, and then week 24. Each tiny dot represents one participant's percent change in NFL at the given visit or a given week. The violin shape show how spread out the NFL measurements are across the groups at each time point. The dashed horizontal line here represents 0% change, meaning no difference from the baseline. And the blue lines here is the small trend that shows the average direction over time. So what we see is that overall distribution remains centered close to 0 across the 6 month period. And that means that on average, NFL levels in the placebo group from the HEALEY ALS Platform Trial did not systematically increase or decrease over this 6 month time frame. And you may notice that individual measurements sometimes go up and down, above or below 0. And this should match what we have seen already in the last page. And again, this change does not necessarily reflect meaningful shift in the disease activity over such a short interval. And I think that we have one table to quantify this in a statistical way, and I will show it in a bit. Next slide, please. Okay, so far we looked at individual trajectory and the group level trends over time. And that actually raised another follow-up question. Does the number of the measurements and how long someone is followed affect what we see? We have some observations from this from a different study, and that's a longitudinal observational study, answer ALS study. Because that study followed participants for a longer period and also incorporates the participants with varying number of the measurements. On the left-hand side, we estimated each participants' monthly rate of change, or say the slope of NFL, and each dot represents one individual here. The panel are grouped by how many measurements, or here I say the visits that the person had. If someone only have two measurements, even small short-term difference can, you can see, make the estimated slope appear quite large and either positive or negative. But we can see that more measurements over time gives us a more reliable estimate of the change. And we can also see that even with longer follow-up, say 12 months or even 24 months, the average slope remains close to zero, regardless the measurements, meaning that there's no clear systematic shift over time. On the right-hand side is waterfall plot where participants are ordered by their estimated NFL slope, showing in small vertical small vertical bars from the lowest to the highest. The colors indicate whether they are within the 12 months or of the symptom onset or 12 months or more from the symptom onset. We do not see a constant pattern between where being closer to the system onset automatically lead to a positive or negative slope. And in the lower portion of this figure, we show how many visits or measurements each participant had. One pattern again shows very clear that participants with who had only two measurements tend to be estimated with more extreme slope. As the number of visits or the measurements increase, the slope estimate become more evenly distributed and less extreme. This tells us that the estimating change from very limited measurements can somehow exaggerate the variability and may possibly not reflect the long-term trends correctly. This does not mean that individuals with two visits are working more or less quickly, but the message is that the decision should not be made based on a single short-term change, and more periodical measurements do help us to understand what the trend may reliably look like. Okay, next slide, please. On this final slide, we ask a broader question: can we predict whose NFL levels will increase or decrease over time, say a 3-month period, based on the clinical characteristics? This analysis comes from again, the Answer ALS observational study. We examined several clinical factors, including the diagnosed tab, the disease tab, borrower status, diagnosed certainty categories, ECC, the EEC, and the time from symptom onset. The table summarized whether any of these factors was associated with the baseline level of NFL and the rate of change in an NFL over time. So when we look at the baseline level, which here in the table is shown under the column called intercept, we do see statistical difference across the diagnostic groups. For example, individuals with familial ALS has a higher baseline NFL level compared to the individuals in the sporadic ALS disease group, and both significantly higher than the other disease groups. Similarly, within the sporadic ALS, individuals with bulbar side tend to have higher baseline NFL compared to the non-bulbar onset. And however, when we look at the slope, the second chunk of the second part of the table on the right-hand side, the picture is a little bit different. In the sporadic ALS group, overall, the estimated monthly slope was about 0.2% increase per month, which was not statistically a meaningful change or meaningful difference from 0. And we compared, and there's no significant difference were detected between when we're looking at across the different diagnosed tabs. When we compare the bulbar versus non-bulbar onset within the sporadic ALS, this was only the actually this was only the subgroup that we observed a statistically significant difference in the slope. And specifically, the estimated slope for non-bulbar onset was approximately negative 0.06% per month. For the bulbar onset, the estimated slope was positive 0.96% per month. For other subgroup comparisons, we did not see the significant difference in the slope. So what does this mean to us? Baseline NFL levels differ across the clinical groups, which line with what we understand about the disease biology, but such the 3-month periods rate of change in NFL are generally small, and from this specific data sets not strongly predicted by the clinical characteristics that we are interested in here in this table. Okay, so that's basically all that we're sharing today, and happy to go through some of the questions from the audience. Thank you.
And James, you're muted, but I can only imagine it's a glowing review of
Oh,
Dr. Wang's presentation.
very, very thoughtful things that I was saying now. I've forgotten most of them, but no, that was wonderful, Jenny. And I just wanted to let kind of the audience know that this is really helping to clarify some of the big questions that we have as we think about this as a tool that we use in clinical trials, and where it might give us answers and where it could potentially lead us astray. So we want to minimize the chances that it leads us astray by designing a trial the right way. And in order to do that, we need to understand neurofilament. It's also a test that we're using in clinic now. So to understand, for example, that, 2/3 of people have almost a 50% increase or decrease in neurofilament at some point over time is really helpful, because then, we can, if we see a change like that with a patient and we're looking at that together, we can think about, whether that really means something has changed or whether it might just be variability that isn't related to ALS. And that question, in fact, crossed my desk once yesterday and once today from patients. So I think it's a big, big thing. So we have one question: is there a difference in NFL blood assays between 2nd and 3rd generation analyzer machines? I think, Jenny, I'll take this briefly. And over time, we have gotten sort of a number of different approaches to measuring neurofilament. And some of them have to be done in plates. So that means you have to test, 60 samples at the same time. Some of them can be done one at a time. Some of them manage variability on the actual assay a little bit differently, I should say. And so they all have sort of slightly different turnaround times, slightly different strengths. And interestingly, they all have different actual ranges of numbers that will come back. And so that's a little bit confusing, that these different assays have different normal ranges and different spreads of the numbers that we see. So if someone is having their neurofilament checked clinically, it's important to know whether it's being done at the same lab or a different lab than previously. In clinical trials, we manage that by using one assay and doing that for all the samples all at the same time. There isn't, at this point, a huge difference in sensitivity or specificity kind of characteristics of these tests, but the numbers that come off the assays themselves do differ, and the practicalities differ a little bit. It's good to have different options. And let's see. So there is a question: which drugs in the trial showed the biggest effects on neurofilament light levels? And I guess what I would say is, first of all, that, Jenny, what you presented today was all on placebo. And so we're really trying to understand what happens if you don't treat. if we think back to the papers that have been published on the trials, the CNM-AU8 drug did show that there was an increase in the placebo neurofilament that we did not see in the treated neurofilament in the platform trial. And that was a difference that we saw only in that trial. It was a difference of on the order of 12%, and I'd have to double check that number, but it was on that order. It could have been 14% over those 6 months. And we did not see that in the other regimens. Any thoughts on how receptive FDA is to allow NFL as a biomarker when considering approval? It's a really important question, and I think the work that it was either the important or a very important piece of the approval of tofersen. Tofersen also showed clinical benefits, though it didn't meet its primary endpoint at the time point that they pre-specified. So I think their neurofilament was a really key piece of the approval. Going forward, I think that I can't speak for the FDA, but I think that there is a broad excitement about neurofilament changes, indicating future changes in clinical measures. Jenny, one of the questions that comes up after that is how much change do we need to see? And I wonder, from a statistical perspective, how you think about that question. How much change do you need to see how much difference do you need to see between a treated group and a placebo group based on the numbers you just showed us? Oh, you're muted. I did it, then you did it. Yeah,
Yeah, sorry. It's related to several things. It's similar to the question about the one that I heard the other day about what is the significant decline in the NFL. It's almost the same thing, but I think those are really depends on how well, so how the sample size that we realistically can have, and how much how the other factors are interplay. How the other, for example, like we are thinking about the stratifying by also age, some other factors can interplay here to decide that. So we are running. As I myself in the MATch program, we're running a lot of simulation to see that the power change and the sample size change to detect the enough effect between the treated and the placebo group in terms of the NFL. And that's why that we focus on a lot on in the current research, as I just show here, the variability of the NFL. Like those are very important factor in the calculation, in the simulation, and we try to understand what it show as the background in the placebo group and what possibly it is in the treated group, and that will also impact the effect size as well.
Yeah, part of what we hear in your question and the uncertainty in answering it is that, and I want to highlight this, we're not certain exactly how much change in neurofilament we need to see in order for that to be most relevant as far as sort of like, is that a meaningful change? So, Jenny might do her work and say, well, statistically, there's a difference between these two groups. And the question then becomes, is that a meaningful difference between the two groups? Is that a difference that we think really portends a difference clinically between the two groups? And we're still working through that as a community, and understanding how much change we see in people without being treated is really important to our thinking about that. Okay, then there's a question about neurofilament being things other than ALS can affect neurofilament. So if someone has a fall and a head injury, then that can make the neurofilament go up, independent of ALS. And is that at play here? And I think the answer is, we see that a substantial number of people have changes in their neurofilament, and those changes don't seem to correlate with progression of the ALS FRSR. In other words, there are some people who have an increase in their neurofilament without being treated in the sort of placebo group, and it doesn't seem to affect the rate at which their disease progresses. And so that change in neurofilament is something other than ALS, and it could be a number of things. It could be variability in the instrument that's measuring it, which actually tends to be pretty small. It could be variability in when the blood is sampled, potentially. But a big one is there could be something else happening to nerves, like a fall and an injury to nerves, or some other sort of injury that's unrelated to ALS. And then it may just be how neurofilament is made and created and disposed of in the body. There may be some cyclical variation to that we don't totally understand. So that's a really good question. All right, I think we're over time, and let's see. Well, there may be. Which is the best measure, blood or cerebrospinal fluid for neurofilament light? We'll handle this briefly, and then we'll say goodnight. So I don't think from what we know now, it's not clear that there is a best place to measure it. We think that the correlation, at least in an untreated state, the correlation between spinal fluid neurofilament and blood neurofilament is quite high. So if you measure it and it's elevated in blood, it's likely to be elevated in CSF as well. CSF meaning spinal fluid. It's easier to detect in spinal fluid because its concentration is high. However, our assays are good enough that we can detect it very well in plasma as well. It's easier to get blood than spinal fluid. So that often wins the day. Now we don't really know. There's still a few things we don't know. We ask ourselves, could there be a scenario where neurofilament changes more rapidly, differently, to a different extent in spinal fluid than it does in plasma? And that's a question that we don't have a perfect answer to. Eventually, the body seems to sort of make those two things correlate to one another. But if we're giving a drug that's somehow changing the equilibrium, it's conceivable that there could be differences, and it might be important to measure in both places in some of the experimental therapies. We could talk all night about neurofilament. It is so important for us as we're developing drugs. It's so important to doing faster trials. It's so important to predicting what might happen in the future as far as a drug effect. It's helping us think about prevention trials in people that might be at risk of ALS. It's helping us think about how do we move from early phase trials to later phase trials. And it's helping us understand how to talk with people that we take care of in clinic about what is happening to them and what might happen in the future. And if we're going to put that much importance into a tool, we want to do a lot of work to understand it and understand where it may give us answers that aren't quite right, and where it may give us really, really good answers. So that's what tonight is about, and that's what's going on in the background a lot. So thank you for being here.
Thank you, Dr. Berry and Dr. Wang. And to those who are joining us for webinars down the road, we look forward to seeing you then.